Yeah, so good afternoon, everyone, and welcome to this important initiative on respectful abortion care. Thank you very much, each one of you, for joining in. And this is a flagship program of our president, Dr. Shanta Kumari, and it is being conducted in partnership with the WHO, the India office, and Foxy. Both together have initiated this massive program for Foxians all across the country. Just to give you a little background in terms of unsafe abortion continue to be the top leading, or rather the third leading cause of MMR in our country. And it's almost like, 2 out of 3 abortions are deemed to be unsafe in our country. And therefore, the importance of this entire initiative to be taken forward. Although MTB has been legalized and has been part and parcel of the entire country's outlook for several years or decades. It is just recently that, owing to the ground realities, that we have seen certain amendments being carried out in the MTP laws and the rules, which came into force in the month of March and in the month of September 2021. So that's where we are coming from, and that's where we wanted to bring this to the awareness level and the information to each one of you who are participating here, so that you're clear in terms of your understanding and to take this process forward. The entire session is going to be for about 2 hours, in which we'll be covering 4 modules. The first module or the topic is going to be the MTP amendments in 2021, so that each one is aware and informed of what these amendments are and how they impact and affect you. The second module is on safe abortion technologies, essentially what is happening and how it is happening. And I'm sure many of you must be already practicing it. So for some, it may be a reiteration of what is happening, and also to lay emphasis on the fact that now what WHO is propagating is what needs to be once again brought to the fore, so each one of us are on a common understanding and a common platform. The third session essentially is going to be on the Saver Kit, which is safe abortion value and the respect care of an individual who is undergoing something as important or as complicated as an abortion, and that needs to be done. So that will be the third one, and the fourth one will be the pre and post counseling, what needs to be done, including offering what kind of contraception one needs to avail of, and what options are available given the current circumstances that the woman is, and the availability of all of that in the areas where the woman is coming from. So with that, we will be walking you through this entire process. And also, we have 4 faculty with us over here. We have Dr. Babita, who will be along with Dr. Bhanumati, Dr. Bharti, and Dr. Supraja, who will be conducting these 4 topics and walking us through these 4 sessions for the benefit of each one of us over here. Before I hand over to Babita to carry forward the first presentation, I would like to show one slide for all of you all. Please take a note of this, because post feedback and post test and feedback are compulsory for certification. And therefore, this is what you will see when you exit and when you leave the meeting. You will see something like this coming to you when you leave the meeting and exit the meeting. So there is continue and there is stay on Zoom US. Click on continue. Please click on continue to participate in the short survey, which is nothing but the post-test and feedback. This is the kind of screen pop-up that you will see when you leave the meeting today. Click on continue. The instructions here are very clear, so as to be able to submit the post-test and feedback. And this will help you in recording the post-test and feedback and become eligible for your certificate. And Another word of request: as soon as this meeting ends, do not send us an email that we have not received a certificate. We are fast, but we are not so fast. So give us few, days before we can actually come back to you. Thank you very much. Over to you, Babita.
Good evening, everyone. Sir, shall I share my screen itself?
Yes, please. Go ahead.
Okay. Is it visible to everybody?
Not yet. Not yet.
Is it now?
No.
No.
Yes, please. Yeah, now we can see it.
Okay.
You have to make it a slideshow.
Done. Is it visible for you all? Is
Not
slideshow?
visible as slideshow. It's still in your slide mode.
Okay. Just.
Yeah, that's the button you need to click again. Let's see, it comes on. Unless you're.
I'm able to see on my screen. Is it visible now?
Then I'll, Sriman, can you help us, please? You can close your screen, Babita.
Close it.
Okay. Sure. Yeah.
Sure. And you can take it forward once the screen is there, and with next whenever you want to change.
Shall I try it again?
No, he's doing it.
He's doing it. Okay, fine.
Just a minute, sir.
Yeah.
Babita, can you retry again? I don't know.
Yeah, I shall do that.
It's taking time. What's wrong?
Is it visible now?
It's visible, but not in screen. I'm at full screen.
Not in slideshow.
Again.
Madam, I'll share my screen, madam.
Okay, fine. Yeah.
Is it visible, sir?
Yes.
Yes. Okay. Good evening, everyone. Sorry for the technical glitch here. So here we have assembled for an important event today. We'll start with the first module, that is the Medical Termination Pregnancy Amendment 2021. A few details about it, so that whatever we have already heard and we already have read, let us be formally ready with the important modifications and points and be familiar with it. Next, please. So today we'll take a closer look at what are the new laws and what are the changes in the rules of the MTP amendment. Why is it, next please. Why is this MTP Amendment Act so important, or as such the concept of safe abortions important is the unsafe abortions have a lot of burden on the health system of India, so much so that it is the third leading cause of maternal mortality, causing 8% of the maternal deaths per year, and nearly 2 out of 3 abortions performed are deemed to be unsafe, and half of the pregnancy related deaths in women and girls are under 24 years of age. So what is this safe abortion? Next. The safe abortion is one which meets both the criteria, being one conducted by appropriate methods and conducted by a trained person. So both of these criteria need to be met for an abortion to be considered safe. If only one criteria are met, still it is not considered safe. It is considered as less safe, and if not, none of these criteria is met, it is taken as unsafe abortion. Next. So this MTP Amendment 2021 is mandated by law, and it was next passed in the law was mandated in March 2021, and the rules were mandated and passed in the Indian Gazette in September 2021. So let's go through the amendments one by one. So first was the modification in requirement of the provider. Previously, there was a requirement of one provider or the RMP for MTP up to 12 weeks, and two providers' opinion for MTP for 12 to 20 weeks. In the recent amendment, the requirement of opinion of one RMP is required for termination of pregnancy up to 20 weeks of gestation, and the requirement is of two RMPs opinion for pregnancy termination between 20 to 24 weeks. So what is the potential outcome of this amendment is that there will be increase in number of facilities which is providing the service, especially in public sectors like primary health centers for providing services till 20 weeks of gestation. Next. Next is the definition of a vulnerable group of women. So, and this MTP was permissible previously beyond 20 weeks only when it is immediately necessary to save the life of the women, and no other clause was included. Here, the upper limit gestation is enhanced from 20 weeks to 24 weeks in special or vulnerable categories of women, which we'll be discussing later, and also enhancement of birth defects not compatible with life with the medical board consensus. So what is the advantage or potential outcome of this amendment is increased access for vulnerable women to safe and legal abortion services defined by the rules committee, including violence victims, minors, among the others. Next. Next slide, please. So modification for birth defects is previously the MTP Act had provision for termination only up to 20 weeks, whatever be the birth defect or the anomaly. The provision was only up to 20 weeks. But now with the 2021 amendment, the upper gestation limit does not apply in cases of pregnancies with substantial fetal anomalies diagnosed by a medical board. I repeat, the upper gestational limit does not apply in cases of pregnancies with substantial fetal anomalies diagnosed by a medical board. This will lead to increased access to safe and legal abortion services who often seek service late beyond the legal limit for termination of pregnancies, and it may be diagnosed late or the anomalies may be an evolving anomaly. For whatever reasons, the women who are approaching late beyond the legal limit will now have an access to safe and legal abortion, thus reducing the unsafe abortions and also the number of court cases. Next. So another very important modification is regarding to the marital status of the women seeking abortion. Previously, the condition of failure of contraceptive was applicable for only married women or her husband. But now the condition of failure of contraceptive to be extended for any woman or her partner regardless of the marital status. So this has an increased access to safe and legal abortion irrespective of the marital status, especially with the upcoming change in the legal age of marriage from 18 to 21. This important advancement for increasing access to safe abortion. Next. So regarding the privacy of the women, another clause has been included for strengthening the privacy. The name and other particulars of a woman whose pregnancy has been terminated shall not be revealed to any person except to a person who is authorized by law at the time being in force. And also regarding consent in case of minors, very important point is that with the minor, consent can be taken from a guardian. This definition of guardian has been expanded. It need not be a parent, it need not be a partner, it need not be her husband. It can be any adult that is above 18 years of age who's willing to take the responsibility of the women in question can give a consent in form of guardian. So this is an important point where we need not wait for her partner or her parents. Any adult can give a consent and will be okay to take the responsibility. So this increases the privacy and confidentiality of the abortion seekers, and it safeguards the right and dignity of a woman, providing respectful, bias-free services, including counseling and also contraception. Next. So salient features in the MTP Amendment Act is it prioritizes confidentiality and safety of the women seeking abortion, and also the ground of failure of contraceptive has been extended to women and her partner regardless of the marital status. Next. So the rules under MTP amendment, the new rules are, it defines special or vulnerable category of women, the norms for registered medical practitioner, and also the power and functions of the medical board. These are the new rules under the Amendment Act 2021. Next. So the extension of the gestational limit to 24 weeks does not include all the pregnancies or all the women, but only a special category of women will be eligible for MTP between 20 to 24 weeks. Those are survivors of sexual assault, rape, or incest, women with pregnancy in humanitarian settings like disasters or in emergency situations as declared by the government. If there is a change in the marital status during the ongoing pregnancy, like a divorce or a widowhood, women with physical disability, that is the major disabilities as per the criteria under the Disability Act, mentally ill women including mental retardation, minors that is less than 18-year-olds, and fetal malformation that has substantial risk of being incompatible with life, or if the child was born, it could suffer from such physical and mental abnormalities to be seriously disabled or handicapped. So these are the categories, special category of women or vulnerable women who will be eligible for MTPs between 20 to 24 weeks. This will be on an opinion with the 2 registered medical practitioners. Next. The second new rule is the definition of RMP is the same, but the number required is different. So who is an RMP? That is registered medical practitioner who can perform MTP will be the one who has assisted in 25 cases of MTP, of which at least 5 done independently in a hospital. Medical practitioner who has completed 6 months of house surgency in obstetrics and gynecology. Medical practitioner who holds postgraduate degree or diploma in OBG. Medical practitioner who has experience of at least 1 year of practice in obstetrics and gynecology. This is the definition of a registered medical practitioner. Up to 20 weeks of gestation, opinion of 1 RMP is required. Between 20 to 24 weeks of gestation, 2 RMP's opinion is required. And beyond 24 weeks, it is the medical board which decides whether the pregnancy can be terminated or not. Next, third rule, new rule under the MTP Amendment Act. Next is the medical board. Another additional category has been added for termination up to 9 weeks. An RMP with experience of practice of obstetrics and gynecology at any hospital for 3 months is required, or training with performance of 10 cases of MTP by MMA under supervision of a registered medical practitioner in a hospital established or maintained or a training institute approved for this purpose by the government. So this is an additional category of RMP which has been added. So this is for termination up to 9 weeks with medical methods. Next. So the norms for the MRP whose opinion is required for termination at different gestational age. Till 9 weeks experience and training requirement for the registered medical practitioner. One is experience at any hospital for 3 months or perform 10 cases of MTP by medical methods of abortion under supervision of an RMP. Second is practitioner who has assisted an RMP in performance of 25 cases of MTP, of which 5 has been done independently. So this we just went through. Next. This is till 12 weeks. So this the first rule does not apply. Rest of it is the same. That is 25 cases of MTP, 5 of which has been done independently, holding a postgraduate degree or a diploma, 6 months of house surgency, and or 1 year practice in OPG. This is requirement till 12 weeks. Next. Beyond 12 weeks till 20 weeks, the RMP needs to be having a postgraduate degree or a diploma in obstetrics and gynecology. He needs to have 6 months of house surgency in obstetrics and gynecology, or she should have an experience of 1 year in the practice of obstetrics and gynecology, and 1 RMP's opinion is required. Next. Beyond 20 till 24 weeks, again, the same requirements for an RMP, but the difference here is opinion of 2 RMPs is required. Next. Beyond 24 weeks, the experience and requirement will be postgraduate degree or 1 year in practice of obstetrics and gynecology. But here the opinion of medical board is required. When advised by the medical board, the RMP can carry out this termination with all the safety precautions along with appropriate counseling and an approved place. Next. So what is a medical board and what is its composition? There are few suggestive points made in the MPP Amendment Act. So it can, next, it can include previous slide. The head of the institution or the hospital can become the chairperson, and it can include a women doctor, a pediatrician, or any other specialist required for the case can be co-opted. For example, if the anomaly may be a cardiac anomaly or a renal anomaly, in that case you can include a cardiologist or a nephrologist in the board. So this is the composition of medical board, and it is a state specific board. So if you are applying for a medical board, it needs to be from your state. Next. So what are the powers of medical board? The power would be to allow or deny the termination of pregnancy beyond 24 weeks of gestation only after due consideration and ensuring that the procedure would be safe for the women at the gestational age, and whether the fetal malformation has substantial risk of being incompatible with life, or if the child were born, he would suffer from such physical or mental abnormalities to be seriously handicapped. So this is the first thing that the medical board has to decide, to whether allow the termination or deny the termination. Second power it has is to co-opt with other specialists in the board and to ask for any additional investigations if required to decide on the termination of pregnancies. So to note, FOXI with the ministry guidance and WHO support as a part of respectful abortion care is wanting to operationalize and host medical board information on the website so that everybody can have access to this. Next. Next slide, please. So what are the functions of the medical board? The functions would be to examine the woman and her reports who would approach for the medical termination of pregnancy. And there is a timeline which is taken care of. That is, the medical board should provide the opinion in the prescribed form D with regard to the termination, whether they're allowing the termination or rejection of the request within 3 days of receiving the request. So the timeline is very, very clear. Upon receiving the request, it will have the medical board has 3 days of time to decide whether the pregnancy can be terminated or not, and to ensure that the termination procedure, when advised by the medical board, is carried out with all the safety precautions along with appropriate counseling within 5 days of the receipt of the request. So the termination procedure also has a timeline. It needs to be done very safely within 5 days of the receipt. So here FOXI also has an important role to make sure that there are functional boards in every state. As I mentioned before, it is state specific, so that each state should have a medical board, and such access will be very much easier. Next. Next. So importance of the whole training is, already the abortion is legal since a long time in India, which is very much liberal compared to many countries. But now it is time to make it safe and respectful. So the respectful abortion care theme will be successful, hopefully. Yeah, I am at the end of my topic. Any questions? I think in the chat box, we would be appreciated.
Yeah, colleagues, if you can put in any questions or anything that you would have in the chat box, and we will try to address them at the end of the session. With that, thank you, Babita, so much for walking us through this presentation. I'm sure there would be many questions over here, because
Yes.
quite a bit has changed, and it is going to affect, and in a better way, for the
Right.
women of our country who definitely need something like this for themselves. On that note, can I request Bhanumati to please
Sure.
speak on the next topic, please?
Yes. Good afternoon, everybody. It is my pleasure, privilege to take part in this initiative jointly done with the WHO and Government of India by FOXI. It's a very great initiative, and I think we need to. I'm just sharing my screen. And my topic given was safe abortion, the methodology, and how to go about in a proper way. And it really means already
Bhanumati, we have changed the serial
no.
number of the topics. So I think you're downloading Bharti's presentation, if I remember rightly. I think yours is back to number 2.
3A module, sir. 3A module. So 1 minute. I will just tell.
That was changed after yesterday's confusion. I think it's back to -3.
That's why I verified in the beginning. This is the one because in my email it was mentioned like that. That's why module, and the thing is there, safe abortion.
Yes, that's right.
Yes.
That's the one you have to take.
Yes, sir.
This we have just changed the numbering there.
Is it correct, sir? Is it correct?
Yeah, it's fine now.
Okay. Thank you for that. It's a great opportunity given to us, and it's our bound responsibility as well to disseminate this uniform knowledge of doing the safe abortion, so the health issues of the maternity will be better. And in this the overview of this topic will have the existing guidelines and the 3 important portions, like a pre-abortion assessment, medical methods of abortion, and surgical methods of abortion, and post-abortion care also. And WHO has taken a lot of pains and issued many books, guidelines, starting from safe abortion technical and policy guidance for health system and medical management, and the recent one will have a post-abortion care also included. And we have really a very nice road map to by the WHO safe abortion guidelines, starting from 2012, and from the technical and policy guidelines, and a small book is written by the released in 2014, and later on post-abortion contraception is included in 2015, and again revised the guidelines in 2018, and the latest one is the consolidated guidelines on the self-care intervention for health. In addition, the national guidelines also given, India has given, released 2 books regarding the how to go about for the safe abortion applicable to Indian population. We have been listening to Madam regarding the change in the pregnancy, medical termination pregnancy amendment recently done, which is a welcoming one, and it has been done elaborately by the previous speaker. So I will just go through that. And all guidelines are set very clearly. The main key areas here are, as mentioned, the pre-abortion care, the abortion care methods, and the aftercare and follow-up, including the post-abortion contraception and counseling. This has been very much emphasized regarding the post-abortion contraception and counseling, so that the people are educated and future health and their attitude will be entirely different, so that the number of abortions can be reduced. The woman is all in all aspects, she's been involved in decision making. So starting, we will get the medical history, physical examination, and relevant investigations will be taken up, and discussing definitely we will give the open up the basket of the options, so that she will take it for a decision making. And what is that? Next slide. Sorry, there is a the pre-abortion assessment and counseling is the number 1. In that we have the as usual, any patient when they come, we have a rapport, developing a rapport, and listen to them, detailed history taking. Nowadays, the age of the patient may be different, and they may be under some comorbidities or taking some medicines, or are allergic to something. So the detailed history, including her general and other pertaining to this problem of pregnancy, and general and physical and pelvic examination is mandatory, as we are before going to any other additional investigations. The clinical examination gives you the best and more than 80% of the diagnosis, and laboratory and other investigations are needed to rule out anemia and other problems. And relevant, suppose already a diabetic patient or anything, blood sugar need to be known, and her blood grouping and RH typing, if she is not aware, if written evidence is not there, it's better. I think that is a better one to have it. And always decision making information on abortion procedures and counseling are the next step to be done. Regarding the examination, and there may be some correlation according to the LMP, the last menstrual period, and the physical examination. We have been taught in undergraduate how to assess the uterine size, but there may be some disparity depending upon the size of the uterus. If it is larger than the expected gestational age or the smaller, we rule out the other. And if it is larger, it is you can think of the wrong dates or multiple gestation or uterine abnormalities such as fibroids associated, or even the molar pregnancy. If it is wrong dates or other non-pregnant, you can always think of the other inadequate menstrual dating or ectopic pregnancy, which can be our surprise, and it can be a threatening for the patient as well. So in the clinical examination will definitely, we must in the pre-ultrasound era, we used to really look into the size, position, and of the uterus, and see whether the adnexa is free. Still, it holds good. And pre-abortion investigations, as we mentioned a little earlier, it's better to know the confirmation after confirmed if the hemoglobin group and RH typing, and if at all if we need some necessary investigations, we need not hesitate. We can go ahead, and because her whole health depends on that also. Ultrasound is not necessary unless to diagnose a pregnancy or not a certain or unknown location, or if you're suspecting ectopic or missed abortion. This is really applicable in low resource settings where the ultrasound facilities may not be there. But nowadays, when we look at the scenario, everyone else, it's an extended clinical examination, ultrasound is there. If you have the facility, you can make use of it with the cost effective. And after the examination, the pre-abortion counseling, which is very important, we need to ask for the thoughts, what are the thoughts about the terminating pregnancy? What is her previous knowledge or current knowledge? And why is she opting for a termination? And then inform her early, always, whatever we want to give her, disseminate some information regarding that. Let's say that early abortion is safe, importance of a trained provider performing the procedure, always safe, and what are the available methods, medical methods, surgical methods, and how long it will take, and the risks and warning signs associated with the abortion method. Without contraception, she can get pregnant as soon as 14 days after an abortion. That point has to be made, inculcated into her mind, so that she will not go in a belief that she will not become pregnant soon after. So resumption of the normal activities, including sexual care, is possible, and will be required telling her regarding the follow-up also. Everything having said that, it has to be documented. Informed written consent. We have been seen that who has to give the consent. The things have changed, so that a responsible adult accompanying can be a person giving, including the patient, can give the informed consent. And decision to accept the post-abortion contraceptive. Sometimes they may accept in that particular situation. Later on, they may not follow it, but doesn't matter. Even if she's not willing for contraception, she will be provided with the abortion services. So we will not withdraw the services like that. And the clinical management, now coming after the abortion we have clinical management of the abortion. It's a technical details. The abortion care, you can divide the gestation age by 12 weeks, less than 12 weeks and more than 12 weeks. When the less than 12 weeks, the combination of mifepristone and misoprostol, or misoprostol only, or the vacuum aspiration. In the other more than 12 weeks of gestation, we have misoprostol only, the same thing, but the last will be the dilatation and evacuation. Definitely D and C, which is not practiced at all, dilatation and curettage is not recommended. As far as Indian government is concerned, we are allowed like that. Until 9 weeks, the only medical abortion is done using mifepristone and misoprostol. And the doses are mentioned here. We'll again see it in detail. The clinical, so we have in the first trimester abortion, we have the medical methods and the surgical methods. Surgical methods, namely manual vacuum aspiration and suction electrical. So we must know what is the mifepristone and tablet misoprostol. The mifepristone is an anti-progestogen, so it inhibits the action of the progesterone. So the continuation of pregnancy will be stopped, and it will cause the even fetal demise or non-viable. Initial oral dose of mifepristone followed by the misoprostol, a prostaglandin E1 analog, facilitates cervical softening, uterine contractions, and expulsion of the products of conception. Effective contractions are there. Usually, they will empty the uterus. So the misoprostol is very advantages are it has got all the cost effective, the maintenance, and available even in low resource settings, and it can be used by even the trained people. So and very effective. So that is why it is very much widely used. There are many protocols available. The protocol, the uniform management has to be followed. That is the reason these programs are conducted. The protocols for mifepristone and misoprostol. We have day 1, the mifepristone administration, 200 milligrams oral, and if she is RH negative, you can give her anti-D along with that 50 micrograms. And day 3, mifepristone administration. Of the mifepristone, you go up to 7 weeks, you can give 400 micrograms of misoprostol, 2 tablets, sublingual, buccal, vaginal, or oral. If the gestation age is 7 to 9 weeks, it can be 800 micrograms, sublingual, buccal, and vaginal. In addition to that, because the process of abortion starting, the patient can experience pain, abdominal cramps, and everything, or vomiting can be there as a side effect of the misoprostol. The analgesics and antiemetic have to be given. Then within day 15, there is a optional of a follow-up, that is the follow-up day. That is for day 1, 3, and then 15th day. Confirm and ensure completion of the procedure, and that is the time you opt for the contraceptive counseling and advice. And when the characters of the different routes of misoprostol administration for the first trimester, when you use the oral, buccal, sublingual, and vaginal, when you compare everything, the vaginal route, the side effects like diarrhea, nausea, fever, and chills are less, and pill fragments also may be visible when you see in the vaginal. That is why it is more opted for the that route is preferred for the termination of pregnancy. If the patient is not willing to do that, get it that way, even the other routes like oral, buccal, and sublingual are given. We can tell how to be kept. It is a proper way of administration. Either the vaginal route, the clinician can help in administering in the vaginal route. She can lie down for 30 minutes, and otherwise, this is a picture showing about the positioning of the buccal tablets and the sublingual tablets. And after that, he should not swallow for after 30 minutes. She can swallow. That is the absorption takes place like that if for effective management. The WHO has given the drug regimens and dose schedule for the medical abortion like this. For less than 12 weeks, you can have the 200 micrograms per oral or mifepristone once, followed by the misoprostol 800 microgram, or only misoprostol regimen also there. Vaginal bleeding for 2 weeks is normal because patients will keep on asking how long it will take because she'll have other programs to go about. We have to really sit and counsel with her that the bleeding will be going on for 2 weeks after medical, like in any abortion. Only thing is she's not hospitalized, she's not undergoing any interventions. Such bleeding can, it's very rarely, it can even go up to 45 days. The provision of the MMA services, it should be available at the primary care level with the referral system. Suppose there is any problem, there should be a referring hospital or the doctor concerned. If with the proper information and letters or documents with the patient, you have to refer them. Additional services may need to be provided for individuals seeking medical abortion, counseling and testing for sexually transmitted infections, and abuse support services, psychological or social services, or other specialist health or medical services should be may be needed to provide this. And in addition to that, if there is anemia, correction with the iron tablets is done. Provide any necessary pain medication. Definitely they can have abdominal pain, so the pain medications are important. Above all, the emotional support and educate her that how she's going to undergo that procedure and cope up with the thing in the after taking the pills for the medical abortion. The follow-up care. Actually, they say routine follow-up not necessary following an uncomplicated medical abortion using mifepristone and misoprostol combination, expecting that it will be a complete procedure and within we expect that the whole the products of conception come out and she'll be relieved of that. A follow-up visit 7 to 14 days after the procedure may be offered to provide contraceptive counseling. That is the time, I think, with having undergone this procedure, she'll be in a receptive mode. Next time, at least what else I should do? And the emotional support or address any other medical concerns or returning to her duties, all those things can be discussed. In case of, the routine follow-up is definitely needed when it is a medical abortion using misoprostol alone, so to access the success of the abortion. Because how long, I mean, whether it is success or failure, it has to be confirmed. The follow-up care, what are we going to do? Assess woman's recovery and ask for any signs or symptoms of ongoing pregnancy, and review any available medical records and referral documents. Ask about any symptoms experienced since the procedure. Perform a focused physical examination for any complaints. Assess women's fertility goals and need for contraceptive services if not provided earlier. But always, even though we have given it in the earlier time, it is better with the pain and bleeding, she would have even forgotten. So it is better we address it again so that she'll be in a mood to register it properly. So to summarize, the day 1, the physical and pelvic examination, confirm the eligibility, whether it is 7 weeks or accordingly the dose schedule has to be taken, and the tablet mifepristone 200 milligrams orally, and offer anti-D if there is a woman is Rh negative. You have to instruct the woman return for the misoprostol administration after 2 days, And it is better to have the contact address and phone number of the facility center where she can go in case of any emergency. Record her experience of any side effect on the MMA card. Usually, 3% of the women may expel completely with the mifepristone alone, but misoprostol schedule should be completed because even a minimal bits can be expelled by the use of misoprostol. Second day visit, what to do? So, because we having said that 3% of the people can expel completely, the woman may say that I have already everything has come out. I need not go to the hospital. Please do not encourage that. Ask them to come on the second visit on day 3. Give misoprostol 400 microgram sublingual, buccal or vaginal or oral. Observe for 4 hours. Analgesics got to be combined, and contraceptive options like condoms and other methods have to be given. Tell the woman mean period of bleeding is 8 to 13 days. She has to be clearly informed regarding that. And the possible side effects like nausea, vomiting, diarrhea, headache, fever, and dizziness because of the she may not take properly. The bleeding is also there, so she will feel really dizzy. So we have to tell the fever is mainly because of the prostaglandins that has to be explained to her, and report in case of excessive bleeding, pain, abdomen, which is not tolerable, and high fever. It is better she can report to the emergency. Even if there is no bleeding 24 hours after misoprostol, then she has to come because sometimes it may not act. So consider giving additional dose of misoprostol. So with this regimen, 75% of the women abort within 4 to 6 hours after misoprostol administration. That's why when you keep the vaginal tablet or oral, observe for them and tell them and go as soon as they should not roam around. They should really go to their resident place and rest so that she won't be exhausted. And third day visit day 15. Pelvic examination, contraceptive options, hormonal condoms, and IUCD, sterilization after 1 month. Usually, that time they'll be really enthusiastic or volunteering themselves for sterilization. So that can be done after 1 menstrual cycle. You tell them you come after a month so that we can see the next cycle resumed, and then we can even go for a sterilization. Because that the woman has to be informed that the immediate return to fertility is possible after an abortion, and report back if there are no periods within 6 weeks of completion of the abortion process. So we must rule out again pregnancy. Ultrasound is done only if the examination does not confirm the completion of the procedure. If you clinically suspect it has not been os is open or partially expelled, and the amount of bleeding, she said, it's not that great, then we can suspect it's an incomplete abortion. We can even ask for an ultrasound to confirm that. The side effects and complication usually pain, nausea and vomiting, diarrhea and infection. And the pain has to be addressed at any point of irrespective of the procedure, whether it is whatever be the procedure, the woman has the right to have the alleviation of the pain. It is a respectful and non-judgmental communication. We have to give verbal support, adequate counseling, and support person. In addition to the pharmacological thing, ibuprofen 400 milligrams. If the persistent pain with failure to respond to these drugs for several hours warrants evaluation for other causes, such as ectopic pregnancy, infection, or incomplete abortion. That's why we should not ignore her symptoms. If she is really making that pain is really horrible, we have to address the issue. Nausea and vomiting, other things are all self-limiting. By reassurance, it will be better. Infection confirmed by physical examination. If it is evidenced, you can start them on antibiotics. So we look into what is if the action for failure or incomplete, what can we do for that? If there is a failure of a medical abortion, offer vacuum aspiration or repeat the dose. If it is incomplete, it's a partially come out, and observe unless heavy bleeding is there. Bleeding dissolved, uterus normal size, then we feel its abortion is complete. If it is not otherwise, repeat the misoprostol 1 more dose, and then we offer surgical method of evacuation otherwise. Then heavy bleeding continues, we have to see what to do when there is excessive bleeding. If the presence of the excessive bleeding more than her menstrual cycle, soaking 2 pads in 1 hour for 2 consecutive hours, Bleeding, you must give her routine care, keep a watch on her vitals and bleeding. She can, after some time, bleeding decreases over there, then we can ask her to go home and take rest. And if there is any problem, she can do. If that is not decreasing or not settling down, watch vital signs, pelvic examination, products of conception seen in the cervical bulging in the cervical canal. We can digitally evacuate the products, because any distension of the viscous really cause pain and the bleeding is not complete. It will keep on coming. The contraction of the uterus may not be adequate to expel it properly. And women are they become stable and bleeding reduces, then again you can observe and monitor for some more time, and vital signs and bleeding PV can be watched, and she can be conservatively managed. If the bleeding still not continues, not under control, ultrasound is definitely indicated, and which can reveal a minimal residual bits. Wait and watch whether it can come out on its own after some time, or products of conception and residual bits are still there. If the woman is stable, we can give her another repeat dose of all the misoprostol. Or if the woman is not stable, you can go for the vacuum aspiration. But if the pregnancy is really continuing without any effect on the by the medical management, then definitely directly go for the vacuum aspiration. So it can be failure, or it can be a excessive bleeding. The addition of another dose, or the how she is stable, all those things matter. Stepwise management can be done. Recording and reporting for the MMA. Since MMA comes under the purview of the MTP Act, the documentation is similar to that required for the other VA procedure. It is mandated to fill the following forms. We all know, and we have been regularly doing. Never underestimate these things. Form C is the consent form. Form 1 is a registered medical practitioner opinion. Form 2 is a monthly reporting form to be sent to the district authority. It is a real data collection, and it will really have a monitoring system, so it will be useful for all over pan India. Form 3 is the admission register for case records. Usually for follow-up and other things, it will be very useful. And so the other method, first trimester, you can go have a surgical methods. We'll see what are they. The vacuum aspiration is the recommended technique of surgical abortion for pregnancies up to 12 weeks. WHO recommends manual vacuum aspiration as the safest method. The procedure should not be routinely completed by sharp curator. That's very, because the chances of perforation are more with the sharp curator. Vacuum aspiration methods. I think most of you may be familiar with seeing this vacuum aspiration. It's a very effective equipment, very handy, very simple, and performed in the same regardless of the type of vacuum used. It's a handheld aspirator. The picture is showing all the parts of the assembled manual vacuum aspirator. It's a very safely designed and a handheld aspirator used to generate the vacuum. It is attached to the cannula of a 4 to 12 millimeter in diameter. It's a very soft, smooth cannulas which will not do harm any when you enter or come out. And cannula can be used in multiple settings, including those without electricity. And IPAs or easy grip cannula size corresponds with the weeks of gestation. Suppose 8 weeks gestation, 8 millimeter cannula is used. So similarly, 10 millimeters for 10 weeks. So this is very handy, and it will be very useful. And then have the electric vacuum aspiration. Here, electric pump used to generate the vacuum. It can accommodate the cannula of the manual vacuum aspiration with the correct size tubings. So cervical priming may be considered for women with the pregnancy of any gestation age to prepare the cervix and make it soft and easy to dilate. Because sometimes in a previous section, or sometimes the cervix may be little firm, even though they are pregnant, it may be little, the os may be little tight. So you can prime the cervix with the priming agent. The recommended methods of cervical preparation before surgical abortion will be oral mifepristone 200 milligrams, 24 to 48 hours in advance, or 400 micrograms of misoprostol administered sublingually 2 to 3 hours prior to the procedure. And otherwise, misoprostol can be administered vaginally also 3 hours prior to the procedure. We have the mechanical laminaria tents are available. They can be placed intracervically 6 to 24 hours prior. Usually 12 hours will be more than sufficient. So 6 to 12 hours will be prior to the procedure. It can easily prime the cervix. And the pain management for plan for the vacuum procedure will be important component. It reduces pain and anxiety and makes a woman comfortable. So there are two components of the pain management. One is non-pharmacological and pharmacological. The non-pharmacological will be providing psychological support, because we always say that really the emotion, when we keep on talking to the patient, the pain that doesn't come. When we give injection also, when we see, and she doesn't feel it. Similarly, the psychological support is very important. Explaining each step to the woman so she's mentally prepared and cooperates well, perform the procedure in a gentle manner and smoothly, encouraging the woman to relax and breathe deeply. Everybody is using this pharmacological methods: anxiety, cervical dilatation, and uterine cramping. For anxiety, you can use anxiolytics, diazepam, lasting for 4 to 6 hours. Sometimes the disorientation, dizziness will be there. For the cervical dilatation, lignocaine, local anesthesia, or ibuprofen can be given. 10 ml of 1% lignocaine lasting for more than 1 hour will be very useful, or you can give the analgesics 1 hour prior to the procedure. Even the same thing will help in for the uterine cramping. But because of the ibuprofen, you can have the gastritis sometimes. When you use lignocaine intracervical, sometimes if it enters into the vessel, they can have seizures. That is why we have to be mentally prepared for the side effects. So how to go about for the manual vacuum aspiration? Get ready with the instrument, check the instrument properly, and ensure the pain control medication is given at the appropriate time. And she has to empty the bladder as for any other procedure. Antiseptic preparation is done. And paracervical block is a very important and very useful one. It can be avoiding the uterine vessel, the positions. You can give the paracervical block and dilate the cervix. Sometimes the cannula itself is sufficient, smooth, because it will be useful to go for that. And then withdraw the cannula 1 to 2 centimeters away from the, it's always subfundic position of the cannula will avoid the perforation. So, and then rotate the cannula from the 10 o'clock to 2 o'clock position with smooth, gentle rotation. So all the walls are taken care, and release the vacuum button. And then you can get, actually, things will be sucked into the syringe. Red or pink foam without the tissue passing through the cannula. When you feel these things, the uterus can be empty. A gritty sensation can be felt. As we are all familiar with this, so it will not be a problem. The cannulas are very soft. You can use it properly. The cervix gripping over the cannula, because the os is trying to close. So you will feel that when you are withdrawing the cannula, you feel it is the gripping, or the cervix is gripping over the cannula, and the uterus contracting around the cannula and increased uterine cramping. So after, always, irrespective of the method you use, always inspect the tissue you have taken out, so that it will, whether it is corresponding to the gestational age, when you, whatever, 6 weeks or 7 weeks or 8 weeks, whatever it is it corresponding? So inspect the tissue and proceed with the contraceptive methods such as sterilization, IUCD insertion, and then always take care of the instrument for the future use with the proper disinfection. Post-procedure care. Monitor her for any complication and provide management as needed. She may leave the facility when she is stable and meets the criteria for discharge. Ensure that the woman has all necessary information and medication prior to leaving the facility. Document all outcomes of the treatment, including any adverse events, in the facility register and client's record card. And suggestions given to her in all aspects will be useful, so that she will not have any, we can even wait for her to raise some questions and then clear her even the sillier, or we may think it's a non very, it's insignificant, but it's better to clear her doubts. Aftercare, it is very important. We have seen the how to pre-abortion and the method, and then the aftercare. Management of abortion complications are important, like incomplete abortion, infection, bleeding, and ongoing pregnancy. That is why we should never underestimate or overestimate whether it's all come. So ongoing pregnancy, if it is there, it's really to be taken care properly. And provision of contraceptive information and offer contraceptive counseling and methods. Involve the male partner as well if possible. That will also bring us the better success for the couple. Assessment of any other sexual and reproductive health needs that may require additional care. Follow-up, no routine follow-up unless misoprostol alone regimen is used. That is it. To summarize, India has made historic progress in improving access to safe abortion. Really thankful to the Amendment Act recently done in the 2021, and it is really covering a lot of things. But in addition, it is addressing all the important safety measures. Not much has changed in technological update in the last decade. As providers, it is up to us to ensure safety and equality, especially in context of the amended law. Along with safety, we also need to focus on respectful abortion services, which are very well designed, and we really appreciate the efforts done by, because the woman reporting for approaching the doctor for a abortion should not feel guilty. She can as well come and get it done in a proper way with the full knowledge that she can have so many options she can undergo without much of complications or side effect. And whatever it is, it will be tackled properly, and she will feel her responsibility of future contraception care. So that is our aim. So every client, public or private, an opportunity to inform, educate, and equip with the proper information on contraception and counseling. We can use the social workers and even otherwise. This place will be very helpful to have to know what are the methods available and how to do the contraception. Thank you very much for the opportunity. We hope we will do the best in regarding this. Thank you very much, sir.
Yeah, thank you so much, Bhanumati, for walking us through this. I guess the entire aspect related to the methodology and the drugs to be used, the equipment to be used is pretty much you are all aware of what to do and how to do it. So this is a reiteration of all that perhaps you have already been doing. And if something is new, you get that bit of information here through this presentation. As I can see on this particular presentation, there hasn't been many questions in the chat box. So we take it that you all are fully familiar to take your understanding forward. With that, I will request Bharati to walk us through the next bit of presentation on the Saver module, which is the flagship module of WHO. Bharati, over to you.
Yes, sir. Thank you, sir. A very good afternoon to all the participants of this webinar, Dr. Ajay, as well as the faculty and the entire team of Foxy here. It is indeed a privilege to be on this platform to talk about a very important component of, I will just share my screen. I hope it's visible.
Screen is visible. We need
Yes.
to make it, yeah. Perfect.
Slideshow, yes, perfect, sir. So all this while we have heard Dr. Bhanumati and Dr. Babita speak about the MTP Act, the amendments, and the quality care and the safe methods we have to do. But as Dr. Ajay rightly said, the flagship of WHO today, the pendulum moves towards the Saver module, where we are talking about safe abortion values based on evidence, and where we respect the woman as well as she is given her rights. So what are we to do in this context? Let's discuss in the next few slides. Well, WHO very aptly describes something called respectful abortion care, which was never there in our dictionary all these years. We were only talking about safe abortions. But however, with the WHO taking up the respectful maternity care from the same algorithm, this has been drawn out as a respectful abortion care is what we need to provide to all our women. who come for abortion services, and I will highlight what are the norms and stigmas which would affect the services of legal abortion and safe abortions, and an update on what is this WHO Saver resource which will be available for respectful abortion care. So what is respectful abortion care that we are talking about? It's a new word we come across in all our meetings. So the WHO was started this respectful maternity care, and we drew some lines from this for abortion care, where we specify that we have to maintain safety during the procedure, maintain the dignity of the person as well as the provider, maintain confidentiality, which is of utmost importance, and we need to ensure that there is she is free from harm and mistreatment when she comes for an abortion, and she is to be enabled to have an informed choice of what she needs to do. And we need to provide continuous support during and after all types of abortion. So we need to take her into confidence and give her the respect, see that she is given the procedure, given the services according to her rights. So in simpler terms, respectful care means you as a provider, or in certain situations as a patient, should be treated and treated with dignity, empathy, and compassion, regardless of your race, ethnicity, gender, socioeconomic status, or reproductive status, whether it is previous pregnancies, previous miscarriages. So when a woman comes to us for an abortion, it is our utmost primary duty to provide her with care irrespective of any of her socioeconomic status, whether she's married, whether she's a widow, or whether she's come with anybody who is an adult, she has come with somebody. We have no right to ask her questions on her, intimidating questions, and we need not be judgmental on her. It is our duty to just give her safe, quality care provided with dignity and empathy. And if ever we feel that something is wrong, she, as a patient, has the right to speak up, and we as a provider also have a right to speak up. And listening to the client is very, very important as a health professional. We need to listen to her demands, and we need to support them rather than being aggressive and trying to intimidate them or just discourage them and say, oh, you've come with, you're not married, or you've had 2 abortions, or why do you want to discontinue this pregnancy? This is not our job. Our job is just to provide her quality service, and hence a fruitful communication by developing a rapport and using simple local language that she understands in a very congenial atmosphere is what we need to provide this person who comes to us for respectful abortion care. So this WHO has a video here, but unfortunately, sir, I'm not able to play the video on my slideshow. So I would request whether we could have the video later on, sir.
1 minute. Let me just try to play it for you. Can you exit
Yes,
the slide screen? Screen show?
Sure.
It is actually very odd that, you're
It's
not
not
able
playing.
to see it.
So I think probably because we have downloaded it and we are playing it on PowerPoint. Maybe it's due to that. Because
No,
it
but
was
that's the
shared
same
on
thing we have done. We have also downloaded
Google
it.
Slides.
I mean, yeah.
But probably I think so next time we could download
Yeah.
the PPT and then put on the slide again, put on the video, again.
At the bottom, can you see my screen now, everyone?
Yes, sir. No, sir. Yeah, we can see your screen.
See, at the bottom, when you take the cursor, you see there's a...
No, we don't see the cursor, sir. It's just showing your list of, just showing your drive. We only see your Google Drive.
No problem. We'll try to sort this, or we'll try to play it from here. 1 minute.
I did try that, sir, pressing the cursor at the bottom of the screen, and somehow it was not playing.
I hope you can hear everything.
We can only hear, sir, but we don't see anything.
Oh,
We are not seeing a screen. Only your Google
Okay.
Drive is there, sir. We don't see the video.
okay, 1 minute. Is it better now? Can you see
Yes,
me?
sir. Yes, sir. It's there now. Yes, sir. Thank you. So this is a short video showing us what are the norms which we generally take it as a norm in the social behavior, and they are the unwritten rules of behavior which are followed in a civilized society. So we take them as norms, and what are these norms? This short video will depict to all of you. Well, here are some examples. What would we say? That during the COVID pandemic, the social norms were put across everywhere that we need to wear a mask, we need to maintain social distancing, as well as we need to sanitize as frequently as possible. And this was expected to be followed by all living in a civilized society. So these are some norms which are acceptable, and we need, and this profanity or talking with a lot of attitudes and a lot of movements is not something that is accepted in a civilized society. And there's something like that with the gender. We have that boys wear blue and girls wear pink, though there's no color. Gender is just a stereotyped type of a manifestation. But I think in coming days, this has also changed. The pink and the blues have gone now. And then it was a stereotype saying that the man goes to work and he's the one who earns, and the woman is the one who cares for the home. She's supposed to be delicate. She's supposed to be humble. This was what a gender stereotype was there, expecting the man to be the earning member and the owner of the house, and the woman to be the caretaker of the children in the house. Similarly, there were norms and stereotypes in sexual and reproductive health that contraception was to be followed by the woman and it was not the responsibility of the male. But I think these are often intertwined, and we need to reiterate these things and talk about the different changing norms and the changing stereotyped messages in today's society. So according to the WHO, good sexual health and reproductive health implies that people are able to have a satisfying and safe sex life, and they have the capability to reproduce and the freedom to decide so. So it is their choice. So it's not that only a married woman should have a child was a gender stereotype, or premarital sex is taboo. These were some gender types, stereotypes which were being followed, which are still being followed. However, what is a stigma? A stigma can be understood as a shared understanding that a person, a quality, or a circumstance is morally unacceptable. So what are the examples? So the examples would be that the sexual and reproductive health stigmas of that the woman has to take the responsibility of using contraception, and if she uses contraception before she's married, she is immoral, and she has no right to use contraceptions before getting married. This, they consider that if she's using contraception or she has an affair, she is immoral. So these are stigmas which are attached, which I think we need to change, giving more values and rights and respect to this woman. A woman coming for an MTP should not be stigmatized, whether irrespective of her marital status. So along with norms and eliminating stigmas and the legal implications, we should be able to provide respectful abortion care to any woman seeking abortion. Of course, we know that selective abortion is illegal. So we have to see that these norms and stigmas are to be valued. Access of reproductive health rights should be available to all women, irrespective of their socioeconomic status. And we need to say no to these people who we are stigmatizing. And we need to talk about what is the impact of the social norms and stigma on sexual and reproductive health protocols on the woman and well as on society. So I will go back to this point where I left, sir.
Yeah.
Thank you. So these are the common norms and stigmas that we see in every society. But, sir, is it visible?
Yes,
It's visible.
Fine.
Yeah.
Thank you. Thank you. Thank you. So when any individual comes to us for abortion care, we need to see that we do not disrespect them or abuse them in any way. So this disrespect or abuse need not be just a physical abuse, like we talk to them rudely or we're intimidating them physically. Why did you do this? And slapping them or pushing them around is not permissible. Even a verbal abuse, like shouting at them or screaming at them. And sometimes, very often in our clinical scenarios, when a young girl who's not married comes to us, we as obstetricians think that we are a motherly figure and we try to tell them, it's not right what you did, you should not have done this. We have no right to verbally abuse that individual because she is an adult who has come to us for abortion care. It is our responsibility to counsel her, give her the quality care, and look after her when she comes to us and respect her as a woman. And sometimes there may be an abuse of power leading to sexual abuse by taking advantage of the vulnerability of this girl, which is a total taboo. And of course, the stigma and discrimination videos have been shown to you, and we need not attach a stigma for just because she has come to us for an abortion care. And of course, if we fail to meet professional standards of care, as has been enumerated by the previous speakers, we are again giving her disrespect, and we are abusing that individual. So we need to provide utmost professional care according to the guidelines and the legal implications. And having a very poor rapport between the woman and the providers, a very common scenario in our busy hospitals, especially in the public sector hospitals, where the women are just pushed around when they come for an abortion care, and the providers or the counselors don't have the patience or the time to talk to them and console them or put a hand on their shoulder and tell them that don't worry, everything will be fine, it's okay, we will look after you. So this poor rapport is again a category of disrespect, abuse. And of course, this is usually due to the health system conditions and constraints. And it is here that the FOXI and the Government of India need to come in to see that respected abortion care with good quality standards under all legalities is provided in the primary healthcare centers, where all women in all socioeconomic status can receive quality, safe, and respectful abortion care. And this again has to be rectified and upgraded by the governments. And of course, no woman is to be ill-treated, and she has the right to information. And if she is under a minor, she has to be protected under the MTP and the POXO Act, and informed consent. And we have to respect her for the choice of method she wants, and we have to treat her with dignity and provide her the quality care as laid down by the guidelines of FOXI, Government of India, as well as the WHO. So this is the time that all of us have to raise healthcare to a higher standards by we are most often providing quality healthcare in safe situations, but we fail sometimes to give them respectful abortion care, which we need to start doing. So what are the domains of respectful abortion care? Though there are many scenarios here, we have to remember these 12 domains of respectful abortion care. She has to be free from harm and mistreatment. We have to maintain privacy and confidentiality, always preserve the woman's dignity, respect her choices. For example, if she has come to us for an abortion, it is our duty to provide her with the services rather than trying to manipulate her or try to tell her that abortion is not good for you, you need to have this baby or you need to have a pregnancy. This is not our job. Our job is just to respect her choice. And of course, developing soft skills for communication very effectively with this woman who may be a vulnerable one at that particular moment, who may be under a lot of mental distress at that moment. We need to develop very good soft skills, give some time and talk to her in simple language and see that she feels very comfortable and in that environment, and she feels very confident that she is going to be respected and also given quality, safe abortion care. And of course, we have to provide the necessary information about what method we're going to do, how long it's going to take, what are we going to do. The procedure could always be explained to her either pictorially or orally, and we seek an informed consent from this individual if she is an adult. And of course, as mentioned in the amendment, if the girl is not an adult, we will have to take any individual who is above 18 to give us the consent for that. And then we have to ensure that we give her continuous access to support, especially when we have MMAs given. We need to be accessible for if in case she comes in an emergency with bleeding or pain, and after that post-abortion care and post-abortion contraception, we should be ensuring that we give them this accessibility. We have to give quality treatment by seeing that our resources, our instrumentation, our setup where we do the procedures have to be according to these standards, and we need to see that we have the adequate resources to provide them the quality care. We have to have a proper referral protocol in place so that in case of abortions, they will know how we will have the resources to send them to the next setup. And we have to provide equitable abortion care, whatever may be the financial status of this lady. We need to see that providing of equitable abortion care, where again the government needs to play a huge role in this. And we have to have availability of competent and motivated providers. So it is not only the provider that is the OBGYN or an RMP, but even our staff members, the person who is going to be with the lady has to be trained to respect that lady, and she should also be competent. And of course, we have to give them advice and commodity security on this. So, sir, this is another video about the Saver kit, which I was talking to you about. And I think this again does not play, sir. I tried playing it here.
Yeah, well, I'll do that.
I'll stop sharing,
just
sir.
tell me, when the video is playing, can you all hear the sound or?
No, we are not hearing the sound, sir. That's why I was speaking.
Okay, no, I was wondering because I could hear the sound. So there's some gap here.
Yeah.
I need to reach back to
yeah,
the WHO
we were not
guys and
hearing.
see.
That's why I was
Yeah,
trying to explain it out, sir.
Yeah, got it.
I'll stop
You can
sharing,
stop your
sir.
screen share and I will.
Sure. So these are the things we need. So this again doesn't have any volume. So the WHO has come out with this Saver kit, that is Safe Abortion Values, Evidence and Rights.
Yes.
So this toolkit is available on the WHO site. And I think Dr. Ajay and Priya will provide us with the links for this because I could not find it on the WHO site today. And this has four.
Tell me again. What?
Sir,
Where is it?
No, Dr. Priya, when she was talking to us, sir, told us that this is available.
Yeah.
On the WHO, but I could not find it there.
Okay, let it go. Let it go now.
Yes, sir. That's what. That's what.
I'll understand it later because it's almost done.
Yes, sir. Yes, sir. So this I understand is a training kit which has been included in the WHO protocol, and that is called the Saver Toolkit. So this has 4 modules which says explore. Then it has equip yourself. So this toolkit will help us achieve the sustainable development goals. So it is engage, inform, explore, and equip yourself. So that's what this kit is going to enable us to do. Yes, sir. So I will go back to just a few more slides, sir. Can I go back?
Yeah,
Sure,
please.
sir. Thank you. Thank you. Yeah, so this is the toolkit, and then so this is the guide. This is another video, sir, guide to avoiding stigmatizing language. But I think we've already covered that we need to see that we do not be judgmental. We did not use any sort of
Has it started playing for you now? Looks like.
Yes, sir. Suddenly started playing.
Okay.
So that was a very excellent video, which shows us that just by using subtle changes in the way we give the terms, we can provide respectful abortion care. So just a little change in our language could definitely help this woman feel that she is a wanted person, she's an important person, and she is being respected. So the momentum has been created. That is, the laws have changed, the amendments have been made to help these women. But dissemination needs association and OB/GYN provider support through the various associations we have, especially through the FOXI and the WHO. And the FOXI base, the members are the largest provider base for abortion care, and we need to turn the pendulum. It's already there, it's safe, it's legal, and now we need to add the last component of respectful abortion care. So thanks to the COVID, that's one thing which has happened, which is good. Online training has become possible, and it has become very convenient to train our providers to provide respectful abortion care. So the MMA uptake has definitely increased, but we need to see that the conflicts with PCP&DT need to be sorted out. So let us all see that our patients are safe, respected, and quality matters more than ever. And we all have to put our hands together to see that though abortions are legal, though abortions are safe, even today we are seeing more than 22 million unsafe abortions world over, and maternal mortality, the incidents that unsafe abortions are the third most common cause of increased maternal mortality. So it is time to strengthen the implementation of these amended rules which have come in. It is time that we prioritize confidentiality and safety. We need to respect them so that we get respected too, and we need to provide them being unmindful of the socio-cultural aspects, keep them confidential, keep them safe, and keep them respectful. That is what this Saver module of WHO tells us. Safe abortion care with values, evidences, as well as rights. So just to recap, and just to maybe shake you up a bit at this time of coffee and tea, we have a few recap questions, which I would just ask you to put your answers either in the chat box, or you could always just put up your hand in the annotations. So according to the World Health Organization, restricting access reduces the number of unsafe abortions. Is this true or false? We would give you 30 seconds to put your answers up in the chat box. Yeah, so most of them say yes. There's somebody saying true. Lakshmi says false. Well, definitely it is false. So you need to understand that what does WHO Health Organization say? That we have to have the proper place, the proper provider, and the proper method to reduce the number of unsafe abortions. Restrictions are not going to solve this purpose of us. So coming to the next question. The slide is not moving, I think. Yes, so the answer is false. So what it needs to say that by according to definition of WHO, we need to have the appropriate methods by the appropriate person in the appropriate place to have reduce the number of unsafe abortions. The next question is the MTP Amendment 2021 requires a minor less than 18 years to obtain written consent from parents, guardians before she can undergo a termination. Is it true or false? I see a true, then I see a false, true. Well, I think there are many people saying that it is true. Okay. Most of them are true. I think this is, we need to have a very small recap here. It is indeed not true. It just says the MTP Amendment 2021, as Babita enumerated, requires a minor less than 18 years can undergo an MTP. It could be with any adult. She can be accompanied by any adult who is more than 18 years. She does not require the consent of a parent or a guardian. If she comes accompanied by an individual who is more than 18 years, the consent is given, we can go ahead with the medical termination of pregnancy. However, if she is less than 18 years, POXO reporting is still to be needed. We have to report the POXO crime, but we have to provide her bias-free services being non-judgmental. So we do not deny the MTP just because she is 18 years. We do the MTP for her. Simultaneously, we do the medico-legal formalities according to the POXO Act. A 30-year-old woman recently widowed wants to get an abortion at 22 weeks. As a provider, it is your responsibility to tell her to continue this pregnancy. Yes or no? No, 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 right. Yes, right. So everybody says a no, and I think you're all spot on. It is a no. We are just there to provide services. We are not there to make choices for her. So according to the MTP regulations, if it is less than 20 weeks, it's 1 RMP, 2 RMPs if it's 20 to 24. And of course, if it's more than 24 with a birth defect, the medical board will take the responsibility. So now the onus falls on each one of us over here. India has made abortion legal, but let us all make it not only safe, let us from today pledge that we will make this a respectful process for these women who come to us for help. Let us respect them and get respected by them. I thank each one of you for the patient hearing, and I thank Dr. Ajay and Dr. Shantakumari and the entire Foxy team for giving me an opportunity to be on this excellent platform. Namaste.
Yeah, thank you, Bharti. That was wonderfully done. And I
you, sir.
especially liked all the Q&A at the end of the session. Certainly question number 2 is a wake-up call.
Yes.
And
it was googly, Ajay.
Yeah, it was a googly because people think parents and guardians. Yes, yes. We like to
Lakshmi
read what we like to read. Lakshmi. Yeah.
Lakshmi went wrong.
We like to read what we want to read.
Yes, I also went wrong.
Yeah. Okay, so that's a good one. And with that, we'll come to the last presentation, and Supraja will walk us through that one, after which we can address some more questions in the chat box, or we can have a one-on-one discussion or a group discussion thereafter for a couple of minutes. Yeah. Over to you.
Yes. Good evening, everyone. So the last topic for the day. Can you see my screen?
No, not yet.
No?
Yeah, now we can.
Yes.
So it is regarding pre and post abortion counseling and leveraging technology for referrals and online consultations. So what is counseling? Counseling is a structured interaction in which a person voluntarily receives emotional support and guidance from a trained person in an environment that is conducive to open sharing of thoughts, feelings, and perceptions. So the components of pre and post-abortion counseling. It is an integral part of comprehensive abortion services, as important as the procedure. The woman may need help in decision-making. Whenever needed, the spouse should also be counseled. Pre-procedural counseling. Help. There are 3 helps and 1 ensure. We need to help women decide about termination of pregnancy, help the woman to choose the method of termination, ensure delivery of complete information about the procedure, and help the woman to adopt a contraceptive method. What is a procedure? You need to ensure privacy and confidentiality, be non-judgmental, and be sensitive. Establish rapport with the woman, use simple language, and allow the woman to clarify her doubts. If the woman has made up her mind for termination, assess her for the procedure. So, the relevance of peri-abortion counseling is we need to counsel. There is a quick return of fertility. It is a good opportunity so that the woman will accept for contraception. You need to counsel her for a minimum of 6 months gap before next pregnancy and discuss the health benefits and better future pregnancy outcomes. 90% of abortion-related maternal mortality can be prevented by ensuring contraception. So, when to start? We can start in the first visit or consultation, and the only exception is when there is some grief involved. So, what do we have to counsel? We need to counsel regarding the return of fertility, which can be within 10 days to 4 weeks, help her with the choices, and also method-specific counseling, discuss all the methods available in the contraceptive basket, and high-risk behavior wherever applicable. If the woman is not willing for any contraceptive method, you should not refuse MTP. You need to try and counsel her after the procedure. If she is still not willing, call her for follow-up in a week's time and then counsel her again. So, assessing suitability for post-abortion contraception. We need to make sure abortion process is complete, there is no existing infection, no injury to the genital organs, and chances of fresh pregnancy should be ruled out. Post-procedure counseling ensures woman has understood precautions and care needed during the post-abortion period. It is an opportunity to counsel her for contraception in case if not previously accepted. Reinforces the need for continuing the use of contraceptive method chosen. So in the post-procedural counseling, continue, reassure, and repeat. Continue to ensure privacy and confidentiality of the woman. Reassure her in case of any problems. Repeat the information about post-procedure care and also the danger signs. If the woman has already opted, then appreciate her immediate care with IUCD or medroxyprogesterone estate, ongoing oral pills, follow-up protocol, discuss regarding continuity and cards. If the woman has not decided, allay her anxiety, discuss regarding importance of immediate adoption and chosen, extended period of adoption, counsel the couple, and emergency contraceptive pills. Post-abortion contraceptive methods. So all these methods we already know, and this is just brush up. So the barrier methods, condoms, they can be used as soon in the first trimester, as soon as sexual activities resume. In second trimester abortions, as soon as sexual activities resume. Additional information, condoms do not have any hormonal side effects, can be used without consulting a health provider, easily available, prevention against STIs, including HIV, enables men to take responsibility of contraception. So IUCD. Inserted immediately or up to 12 days after confirmation of a completed abortion using the surgical method, with MMA inserted around day 15 of the process, provided complete products of conception expulsion is confirmed and risk of infection or any other contraindication is ruled out. In the second trimester abortions, it can be inserted immediately or up to 12 days after the procedure is complete and contraindications are ruled out. So the IUCD is highly effective method. It provides long-term contraception for 5 years or 10 years, can be provided by trained doctors, nurses after the first trimester, surgical abortions by trained doctors only after MMA, and by PPIUCD trained doctors after second trimester abortion. It has no interference with sexual activity immediate return to fertility on removal, and no hormonal side effects. The hormonal contraception, the combined oral contraceptives, immediately or up to 7 days after abortion using the surgical method. With medical abortion, it can be started on day 3 with the dose of misoprostol or within day 15 of the process after confirmation of completed abortion. In the second trimester, abortion can be inserted immediately or up to 7 days, can be started immediately or up to 7 days after abortion. So the additional information can regulate the menstrual cycles, can be provided by all health workers after first screening by trained provider, no interference with sex, offers protection against ectopic pregnancy, endometrial and ovarian carcinoma, and benign diseases such as fibrocystic and fibroadenomatosis. Not suitable for women who are breastfeeding babies less than 6 months old. The long-term injectables medroxyprogesterone acetate can be started immediately or up to 7 days after surgical abortion. With MMA, it can be started on day 3 with the dose of misoprostol. In the second trimester abortions, immediately or up to 7 days after abortion. It is highly effective. Confidentiality and privacy can be maintained, can be provided by doctors, ANMs, nurses after screening by the doctors for the first injection. No interference with sex, no effect on the quality and quantity of breast milk, no estrogenic side effects, offers protection against ectopic pregnancy, ovarian cancer, iron deficiency, anemia, and uterine fibroids. The permanent methods are female sterilization and vasectomy. Female sterilization can be performed after an abortion in the absence of any infection or severe blood loss, concurrently or up to 7 days. Both mini-lap and laparoscopic sterilization can be done. With MMA, it can be done only after the first menstrual cycle. In the second trimester abortion, mini-lap sterilization can be performed concurrently or up to 7 days after an abortion in the absence of any infection or severe blood loss. Laparoscopic sterilization is not recommended. So it is a permanent method of contraception, highly effective immediately, no interference with sex, no effect on breastfeeding, no long-term side effects, and offers protection against ovarian cancer. Now coming to vasectomy, it is performed on males independent of the timing and procedure of abortion. It is very effective permanent method of contraception, no interference with sex, no long-term health risk. Couple must use another form of contraception for 3 months or until azoospermia is confirmed. So contraceptive methods which can be used with MMA are combined pills from day 3 to day 15 can be started anywhere between day 3 to day 15. Injectables from day 3, Sencromen from day 3, and IUCD from day 15. And contraceptive methods that can be given with vacuum aspiration are combined pills, injectables can be given, Sencromen, intrauterine contraceptive device, and laparoscopic sterilization. So the Sexual and Reproductive Health Services, teleconsultation and other technology, leveraging technology service provision by teleconsultation, telecounseling, teleguidance, telereference, and telelinkage. And there are various websites in which all the information is available, and social media like Ask Tanu, YouTube, various infographics and helpline numbers, and patient education platforms, the WHO, RCOG, Ministry of Health and Family Welfare, where the patients can freely go and get all the information required. So the SWOT of teleconsultation, the strength, weakness, opportunity, and threat. The strength for teleconsultation, in the COVID era, teleconsultation has become the main form of communication. It is approachable throughout the process, confidence, awareness, spread out questions answered at ease. The weakness is there is lack of face-to-face consultation and demonstration of how to use the method. Opportunity, because of teleconsultation, there is privacy and comfort, it is cost saving, and a number of visits can be cut down. Threat, missed opportunity, and they can be misdiagnosis. Applicability of components of CAC. Assessment, confirm the diagnosis and contraceptive need, counseling with video conference or Zoom, and follow-up. Hybrid services, 1 visit or for MMA and 3 visits. The key messages are: realize the need of post-abortion family planning services, bring the couple on board and strive for 100% coverage, capitalize on the basket and applicability in the post-abortal period. Technology, as far as you can use the technology as far as possible. Scope for entry in the CAC services. Concern with policy malpractice, service costs and access. Adolescent reproductive health need both offline and online consultation. So this is the end of the topic. Thank you for your patient listening, and thank you for giving me this opportunity.
Thank you so much, Supraja. I know it was last minute, absolutely last minute for you. You were informed about the same, say at around 3 or 2:30 or so, because Padmaja had some emergency and she had to leave. And very frankly, we could make out you tried your best. And thank you very much for trying your best with the short time that was available. Can you stop your screen sharing?
Yeah.
1 minute. Yeah, your screen share has to stop.
Okay.
Supraja, your screen share has to.
Okay.
Yeah. No, it's been a wonderful, session. We have caught up on all the time and just had about 8 minutes loss of time. We are happy to take some questions as well. Before taking the questions, I just wanted to reply on the medical board. Now, this is an extremely gray area of constitution of medical boards and existence of medical boards across the country. Given that there are shortages of, qualified staff to be manning these, and the requirements of the head of the department, or those kind of almost 60 to 80% shortage of people. So therefore, technically speaking, you should have a medical board, but may or may not be having it in the places and everywhere that would be required them to have it. Having said that, we had raised this question with the Government of India and with WHO during our interactions with them, and their only humble request was that they are keeping working at it and seeing how best they can, mobilize the constitutions of such boards, and they were really looking at FOGC to take some kind of leadership over here to enforce and to build a more noise level to be able to get something done at the state level or at the district level. So I do not have an answer yes or a no whether it's there or not there, and how it's going to pan out. And even in my sense, Government of India, concerned people also are struggling and grappling with this issue, and they want to find a solution for it. Having said that, FOGC is not taking ownership for it. One of the questions put up was that, is FOGC going to do, and how should we go about doing it? What should we do, and all of that. FOGC is not taking ownership of a job which the government is supposed to be doing, and it is their domain to be setting it up. FOGC will only be the one who is going to be the facilitator, the one to be asking those questions, and one to be pushing for this agenda to be brought to the fore so that this thing can get constituted to the best of its availability. So I don't have very good news on that, but that's the best we have. So we have to work with what we have and try to see how these isolated cases can still be managed with that barrier of the 24 weeks plus where we have to go to the medical board. I hope and pray we do not end up into more such a situation. Lakshmi, you have anything to add? Please do that.
Ajay, you are absolutely right that as a FOXY, we don't have, that is not in our domain. But as and when the need arises, they do constitute a local medical board and they do take action and they do reply. So ऐसा नहीं है कि, I mean, it's not there कि medical board is not existing at all. It is not like that. Because I'm sure as a private practitioner, you are not authorized to do MTP after 24 weeks. So you have to refer them to the medical college. There, the HOD will inform and they form a medical board and they take appropriate action. So they are not neglected. Necessary action is taken at that particular moment for that particular woman.
Yeah. I think that is about the medical boards. Anything else? I don't think so.
There's one question. They want to know that now that their center is approved for up to 20 weeks, do they need to get a fresh authorization for about 20 weeks? I think it's not necessary. The same approval is enough.
Same. Yeah. One needs to keep following the protocol that you're already putting in place, and that doesn't matter. So it will continue. Yeah.
It is, I mean, you can take it for granted that it is now for 24 weeks of gestation.
Yeah.
And there's another question, where to get the Form C, the MTP forms they mean, I think.
Yeah.
I think they are available in the district health officers in the office as well as on the Government of India websites.
From where your MTP center is recognized, like
it is the
civil surgeon
DHO,
office is authorized. So if you send somebody from your hospital to the civil surgeon office, you will get all the necessary forms.
Yeah, from the district health authorities.
Yeah, I mean, whosoever is in charge of MTP in your district or city.
Then there was a very, very technical question. Now, I don't know if this is the forum to answer that.
No, Ajay, we can't answer all these personal questions.
Yeah, these personal questions.
Because here we are talking about the RAC and we are motivating everyone to provide RAC.
Yes.
Yeah. That is a very...
Yeah, that was a very, it actually, you
with
were
all
talking
respect to the person
yeah, with all due respect,
but that is a very medical question and we can't answer on this open forum.
Yeah. Okay, so maybe you can touch base with few of the colleagues and
take opinion of a senior or a colleague or somebody. I mean, we always we reach out to our colleagues in such cases of crisis. But yes, as of now, Government of India protocol, the electrophoresis is not there in their protocol, but like Vidarbha, we have very high incidence of hemoglobinopathies, that is sickle and thalassemia. So we do, even if it is not there in the protocol, we do. But I know you can't do it for each and every pregnant woman. So you are not held responsible for that.
Right. Any other burning question that is coming up? Because we have, I think, addressed all which is there in the chat box.
Fantastic. I want to acknowledge that all the presenters, they did a wonderful job. Wonderful job.
Thank you, madam. Thank you.
We deserve a loud applause. Yeah.
Yes.
Thank you very much, sir.
Thank you, madam.
Can we request everyone to please switch on their videos so we can have some memory here?
Yes, sir.
Everybody being clicked to a gallery together.
And as usual, I think Ajay is having almost 100 clones. Ajay, you tell me how to do cloning. He is there everywhere. Not tired and he's fresh and he's answering all the questions. I appreciate it.
Doctor, sir, Ajay sir, I see you're the only male among such a huge gathering of women. That shows how popular you are.
I know. In fact, at Bharti, you'll be surprised. I'm surrounded by women even at home.
Oh, that's so lucky, man.
Yeah, so I have 3 women in my life, my wife and 2 daughters.
So now we know the secret of your
I know why, sir. You're so handsome. Sir, you're
And I
so
have 3
handsome
dogs.
and pleasing. That's why.
And I have 3 dogs who are also females. So I have,
Oh, similar,
I'm
sir.
completely
I
surrounded
think
as swamp.
three with me and you are common. I have 3 dogs and 2 daughters, just like you.
Great. 2D club. Yeah.
Chalo.
So let's have a photograph
Screenshot lo.
quickly. Screenshot. Sriman, can you take it, please? Or anybody
Yes, sir.
can take it. Atima has disappeared. Atima, I think you're there tomorrow, right? Where are you now?
Yeah, I have taken the photograph, sir. I will share it with you.
Okay, great. Wonderful. Take it on the next page also. It's good to see. Shaili, please do communicate my regards to
request-
Kiran.
Yes,
Everybody
sir,
to
yes,
put on
sir.
their
I will
videos,
definitely
please.
convey.
Yeah. Can you put
Could
on your
everybody
videos?
put on your
Yeah?
videos? Page number 2. Yes. So the only thing we miss here is a hot cup of coffee or tea.
I had
Virtually,
mine. So
I
yeah.
can send to everyone.
Yeah.
That is the advantage of having virtual meeting.
Before we close, once again, let me share this with you all so that we don't miss out. When you leave the meeting, please
Yes.
click on continue to get your short survey, and you don't miss out on that. Even if you miss out, do not panic and give me a call, because because we will in a day or two send you the links of this post-test and feedback. So hang in there, and we will try to do our best. Sriman, Basir and team are doing an excellent job of making sure the program is running smoothly, and they are the ones who will be communicating hereafter with all the requirements if you haven't submitted the post-test and feedback, and we'll try to do the best that we can to make sure you have it. If there's nothing further, then we can say goodbye.
Yeah.
Thank you very
Goodbye.
much, each one of you, and all the very best. And if you have the opportunity, please go ahead and share with us details of your society where you would like to organize this program, and we'll be very happy to support you for organizing such sessions in your society as well.
Thank you, sir.
Yes, sir.
Really
Thank you, sir.
nice, good
Thank you very much.
opportunity, sir.
Bye. Bye.
All the very
Bye-bye.
best. Bye-bye.
Bye bye
Bye-bye,
to
sir.
everyone.